Picture this, all right? It's 2 p.m. on a Tuesday. You've got a patient in absolute life-altering agony, but you look at her ultrasound and it is practically pristine. Then, literally, your very next case is a routine lap. You open the abdomen, and it's a complete disaster zone. I'm talking a totally cemented pelvis, yet she barely complains of a twinge. Welcome to the explainer. If you've been practicing OBGYN for, more than 5 minutes, you absolutely know this paradox. Today, we're tearing apart the medical dogma that's been driving us all crazy for decades.
So, here's the million-dollar question we're tackling today. Does worse endometriosis actually mean worse pain? For years, right, we were spoon-fed this idea that surgical severity automatically dictates symptom severity. It's this neat, linear concept that looks beautiful on a multiple-choice board exam, but let's be real. How often does that actually match the living, breathing, hurting woman sitting across from you in the clinic? Spoiler alert, almost never. And finally, we have the irrefutable data to back up our clinical sanity.
It's the ultimate clinical mindbender. You've got the completely asymptomatic frozen pelvis on one hand versus the agonizing minimal disease on the other. You find a few tiny superficial peritoneal spots in a patient whose dysmenorrhea is so severe, she's literally burning through her sick days every single month. Honestly, it leaves us questioning our surgical skills, and way worse, it can leave the patient feeling completely invalidated. We've all stared at an op report just trying to make the math work.
Section 1. Why this matters clinically. As busy clinicians, we desperately want to give our hurting patients a score or a stage to explain their suffering. But there's a massive, glaring conflict here. We universally rely on the rASRM classification. But guys, here is the elephant in the room. rASRM was built to evaluate fertility. It is fundamentally a tubal and ovarian adhesion score. It was never meant to be a pain scale. Using rASRM to evaluate debilitating pain is literally like using a tape measure to check a fever. It just leaves this massive gap in our clinical evaluation. Section 2, the JMI-GIG study snapshot. Let's look at the evidence. So this is the brand new evidence base that totally shatters the old myth. We're looking at an incredibly sharp, practice-changing meta-analysis published in JMIG in 2026 by Alves and colleagues. 2,857 women. This isn't just some tiny retrospective TERT review from one hospital, okay? This is a massive, pooled cohort giving us a definitive look at the true relationship between what we see surgically and what the patient actually feels. Let's quickly establish the credibility here without bogging down your burnout brain. This review pulled in 8 high-quality international studies, and they didn't just casually ask, hey, does it hurt? No, they strictly used validated tools like the visual analog scale. Plus, they didn't just lump all pelvic pain into one messy bucket. They separated it out into the heavy hitters: dysmenorrhea, dyspareunia, dyschezia, dysuria, and chronic pelvic pain. Section 3. The big key results. Here's what the data actually shows. Okay, I want you to guess right now which of those 5 pain types absolutely dominates the clinical picture. The reality is totally in the numbers. Dysmenorrhea reigns supreme. It has the highest pooled mean pain intensity at 6.61. That is vastly higher than dyspareunia, dyschasia, and especially dysuria, which sat way down at 1.08. The hypothesis here? It's driven by microbleeding within the lesions causing these severe acute inflammatory storms. So when your patient says her period pain is a 9 out of 10, believe her. That is the biological driver. But here is the massive aha moment of this entire explainer. When we compare pain intensity between early rASRM stages I and II versus advanced stages 3 and 4, the p-values are all greater than 0.05. Statistically speaking, it's a flat line. The intensity of the pain does not differ significantly based on the rASRM stage. Your stage 4 patient and your stage 1 patient are on average experiencing the exact same level of agonizing pain. Wild, right? I want you to take a mental screenshot of this. Stage does not equal symptom severity. If you take absolutely nothing else away for your next shift, let it be this pearl. We have got to stop counseling patients that their pain should be mild just because we only found stage 1 disease. The data completely absolves us and our patients from that totally outdated expectation. Section 4. Real-world clinical interpretation. Let's talk about the major exception to the rule. Because we are senior clinicians here, we know medicine is rarely black and white. There's always a massive gray zone. We have to draw a hard line between general pain intensity and the prevalence of chronic pelvic pain. Remember, the study defines CPP as non-menstrual pelvic pain lasting 6 months and causing functional disability. While the intensity of individual pain spikes doesn't care at all about your ASRM stage, the specific prevalence of everyday chronic pelvic pain actually does. A significantly higher proportion of women experiencing chronic pelvic pain are found in the advanced stages, rASRM 3 and 4, with a p-value less than 0.001. Why? Well, because advanced stages involve massive anatomical distortion, dense adhesions, and a frozen pelvis. That constant mechanical tension naturally leads to persistent, everyday baseline pain. So stage doesn't predict how bad a flare-up hurts, but it absolutely does predict whether she's going to hurt every single day. Section 5. Limitations that actually matter. Let's look at what we missed. All right, it's time to put on our sharp attending hats and analyze the data critically, because no study is perfect. Here is the reality check. This meta-analysis suffers from a heavy rASRM bias. Actually, only one study using the modern ENZIAN classification even met their strict inclusion criteria. Plus, a lot of the studies were missing robust data for dysuria and dyschezia, and the demographics skew heavily toward lower BMI patients in North America and Europe. Because most of the literature relied on rASRM, we are still missing the deep anatomical correlations we really crave.
Section 6. Actionable takeaways for tomorrow. How this changes your practice.
Look, you're seeing 30 patients a day, and you need to know how this actually changes your practice tomorrow morning. Here is your 3-step paradigm shift. Step 1, stop using rASRM as a proxy for pain. Just tell your patients it's a fertility score. Step 2, start familiarizing yourself with the ENZIAN classification, which is actually designed to describe deep infiltrating endometriosis. And step 3, map specific anatomy to specific symptoms. Lesions in ENZIAN compartment B, the uterosacral ligaments, correlate directly with dyspareunia. Compartment C correlates with dysphagia. Map the anatomy to the complaint. It all comes down to this classic but now completely evidence-backed pearl. Treat the patient, not the stage. Validate her pain. If she has intense dysmenorrhea with a visually mild pelvis, her disease is just as valid and her pain is just as biologically real as the patient with a frozen pelvis. We need to trust our clinical intuition over an outdated scoring system. I'll leave you with a final provocative thought. Knowing what the data definitively proves right now, will you still rely solely on rASRM to counsel your next surgical patient? It's time to elevate our game. If this explainer made you feel a little smarter, a little more sane, and a lot more clinically empowered today, make sure to subscribe. We are here to make staying current with the evidence easy, unapologetic, and completely binge-worthy. See you next time.